Good evening, one and all. On behalf of Dr. Agarwal's Institute of Optometry, I extend a warm welcome to each and every one of you for the 43rd episode of Optometry series. The topic for today is Back to Basics. I'm very happy to welcome my team members, Ms. Meenakshi and Ms. Anshima. Hi, ma'am. Hi, Meenakshi. So, Anshi, ma'am, so today we're going to concentrate on the practical aspects, especially on EOM cover test and the pupil examination. So, why did you bring up this topic for today, and who's the moderator, ma'am?
Okay. So, as you all know, we had a very famous tagline, back to school. So, once we start, we need to get back to our basics because we are always climbing ahead to learn further procedures. So, what happens is with time, the students, even us, we have a tendency to forget what are the basic procedures. Most important of it is the documentation part of it. So, today is to start with, this is our first episode of its kind where we are going to revise very simple aspects like how you said that these procedures, but the importance of why do we need to correctly document it. And someone who's been very well in clinical practice is Ms. Daksha. She's a very good optom and she will be really helpful in guiding us as to what are the ways there are different formats available. So if we are picking up one particular format, why is that important and how should we document? So thank you so much, Daksha, for giving your time. And I move over to the MC to please introduce Ms. Daksha today.
Good evening, everyone. I'm Manisha, a second year Bachelor of Optometry student at Dr. Agarwal's Institute of Optometry. I'm very happy to welcome our moderator for today, Ms. Daksha Jain Soni ma'am. Daksha ma'am is a passionate optometrist and academician who graduated from Elite School of Optometry and completed her post-graduation at MGR University. With over 11 years of experience in optometry education, 6 years in clinical practice, Daksha ma'am is currently freelance optometrist specializing in contact lens, low vision rehabilitation, and vision therapy. Ma'am has her own practice and is also a visiting faculty member at Shankar Netralaya Academy. With over a decade of experience in the field of optometry, she believes that regardless of what an optometry does, the ultimate goal is to bring contentment to the person on the other side, whether it's a patient or a student. Daksha ma'am has found that the best way to connect with Gen Z is by stepping their shoes and walking along them. Thank you so much for the contribution in the field of optometry and resonating with the students, ma'am. The presenter for today is Ms. Gnanambighai of second year masters in optometry. Ms. Gnanambighai, please start your presentation.
Hi everyone, I'm Gnanambighai from Optom. Here we are going to see our basics. In today's session, we are going to see the procedure and documentations of ocular motility and cover test and pupillary evaluation. First, we are going to see about ocular motility. In ocular motility, we will see both versions and directions. In versions, where the binocular and conjugate movements of the allowing lines of straight parallel direction. For the purpose, we will examine the extent of version's eye movement in the position of gaze. These are termed as dextroversion, levoversion, supraversion, and infraversion. Dextroversion is the right side, levo is the left side, and supra is the up, and infraversion is the down. So horizontal and vertical combinations of these movements are routinely occurs. Ductions are the monocular eye movement, which is called as abduction and adduction, supraduction, and infraduction. What is the clinical use of ocular motility? Defects in the ocular motor system may result from the lesions in the neurological finding pathway or the supranuclear control center. 1 second. Sorry for the interruption. What is the clinical use of ocular motility? In the clinical use, we will see the ocular motility. If there is any defects in the ocular motor system, may result from the lesions in the neurological finding. Find the common pathways and supranuclear control system. Thus, the problem in the ocular motor system may result from the neurological insights as well as from the mechanical restrictions or functional difficulties. Version movements are tested to determine if there is any overaction or underactions of extraocular muscles. Ma'am, slide is new. What is the instrumentation needed for ocular motility? Any target that can be fixated is useful for measuring the versions and actions. With the young children, the target must be something that is colorful and interesting. Those that make the noise can particularly useful in the attracting attention. The transient illuminator or the pen light is usually an appropriate target for adults. The most commonly used test is broad-hedge test, one of the most useful ocular motility tests. It is designed to test the actions of horizontal rectus muscles and to test the actions of vertically acting muscles, the vertical recti and oblique muscles. The broad-hedge test is interpreted in the terms of field of actions of 6 eccentric muscles. And the field of actions for the given muscles refers to the field in which the particular muscle has the greater action. The field of actions of 4 vertically acting muscles is based on the muscles of plane of each of these muscles. So both superior and inferior rectus muscles lie in the plane that makes an angle appropriately 23 degree with the straight ahead position of the eye. The superior and inferior oblique muscles lies in the plane that makes an angle of appropriately 55 degrees from the straight ahead direction. This picture shows the medial rectus adduction and lateral rectus abduction. There is a inferior rectus and superior oblique, and elevation and intorsion in the superior rectus and inferior oblique. Each muscle has the primary, secondary, and tertiary action. So, clinical procedure for ocular motility. The patient spectacle has to be removed, and patient and examiner should be seated at the 1 meter arm length. The examiner holds an appropriate fixation target with one hand. The target should be about 30 centimeter in front of the patient's eye. It should be begin in the primary case. Then the target should be moved smoothly to the examiner right until they're no longer able to follow. The slight endpoint nystagmus is often observed and is normal. And the target is moved upward until the eyes can't follow and then downward. If the patient can no longer see the target clearly, it is not a problem. We are concerned about the driving the extraocular muscle to the extreme position. The target clarity is not an issue. So results is recorded as no overaction or underaction. Underaction and overactions of specific muscles. Interpretation. Underaction is being considered as positive from +1 to +4. Sorry, overaction is being considered as positive +1 to +4, and underaction is considered as negative. It is rated as -1 to -4. Normal movement is rated as 0. -1 represents the 25% underaction, whereas -4 refers to the eye does not move behind the midline. Whereas +1 represents the 25% of overaction, whereas +4 means the eye does not move behind the medial line. The documentation, it has to be checked and documented as OU, no complaint of plane or diplopia. If there is no movement, 0. If there is a underaction, we should refer -1, and if there is a overaction, +1. Cover test. We need a small and detailed fixation target, proper illumination. We need a cooperation from patient, known correction and known testing distance. So methods of cover test. First, we should do the direct cover test. Procedure for this too, we have to cover the patient's one eye, and patient has to fixate the target. Best corrected visual acuity 1 line above. If the patient's visual acuity is 6/6, the patient has to see 6/9. 6/9 will be the target for distance, and we need to cover the patient's one eye, and the other eye movement is observed. So basically, we will measure the tropia. Here the video represents the direct cover test. We will cover the patient's right eye and we will observe the another eye. And next is cover and cover test. This is to establish the presence and type of heterophoria. For this cover and uncover, same eye movement is observed. Cover and uncover the patient's same eye, and we will observe the movement of the eye. And the procedure video, we will cover the patient's eye and we will see the movement of the same eye. Here we can able to see the phoria because the fusion is interrupted. Cover test is moved quickly and the direction of movement is noticed in the same eye. An alternate cover test. It is performed to establish whether the squint is unilateral or alternate, and also to differentiate the concomitant squint from the paralytic squint. The procedure: patient is to fixate alternately, placing the occluder alternately. So this is the procedure video where the eye has been occluded alternately. It is important to place the occluder alternately several times to dissociate the eye and maximize the deviation. So occluder should be transferred quickly from one eye to another to prevent the fusion. Next, we are going to see pupillary evaluation. The normal physiology behind the normal pupillary construction is the balance between sympathetic and parasympathetic nervous system. Parasympathetic nervous system leads to the pupillary constriction. The circular muscles called the splinter pupillae accomplishes this task. Sympathetic nerve innervation leads to the pupillary dilatation, and dilation is controlled by the dilatory pupillae, the group of muscle in the peripheral 1/3 of the iris. Constriction occurs during the light and near object. Dilatation occurs during the dim light, far objects, and pharmacological agent. And first we will, in pupil, we will see the size, shape, and how many pupils, number of pupils. First we will see the pupil size. The size of each pupil is measured using the millimeter ruler and estimating the pupillary diameter. The measurement should be made in both lighted, semi-darkened room, as the pupil may be equal size in one circumstance and unequal size in another. In contact lens fitting, measure the pupil size in the dim illumination, and documentation should be measured in noted in millimeters. Direct and consensual reflex. To observe and to evaluate the direct and consensual pupillary reflex, the patient fixates an distant object and semi-darkened room. Pen light is used to eliminate each pupil. Direct reflex, quantity and quality of the changes in the size of pupils of one eye when the light is placed on the eye. Consensual reflex is the quantity and quality of the changes in the size of the pupil of one eye when the light is placed on opposite eye. So for direct reflex, we will see the same eye. For the consensual reflex, we will see the we will eliminate the right eye and we will see the patient's left eye. And next is near reflex. The pupillary response is the quality of changes in the size of pupil when the fixation is changed from the distance to near or from near to distance. Procedure: semi-darkened illumination. Patient is asked to fixate a distance object, then asked to fixate the near object, such as the row of letters on the near point card. The size of pupil when the patient refixate the distance target. Procedure: size is normally 3 to 4 mm in the normal illumination. Shape and number of pupil responses in the direct, indirect, and near reflex. This will be measured as parallel. Pupils equal round reacting to light and accommodation. Swinging flashlight test is usually to test the RAPD, relative afferent path pupillary defect. Swinging flashlight test. Swinging flashlight test is the comparison and the strength of the direct pupillary response to strength of the indirect or consensual pupillary response. Procedure: to conduct the swinging flashlight test and patient fixates an distance object in the semi-darkened room. Examiner first illuminate the right eye and then left. Swinging flashlight from the one eye to another. The procedure is repeated for several times, each pupil being illuminated for about 1 second to establish the rhythm. Normally, the pupils of each eye will be seen constrict as that eye is illuminated. The swinging flashlight should be shown to the each eye in the swinging motion. In the presence of Morgescan pupil, the pupils of affected eye will dilate when the eye is illuminated. The pupils of both eye will dilate when the eye with the Morgescan pupil is illuminated. In one, which is in this picture, A is the pupil size in the semi-darkened room. Both will be equal. Both pupils is constricting when the second one, this is both eye is constricting when the normal eye is illuminated. And C, both eye is dilating slightly. This is a case of RAPD. Pupillary anomalies, anisocoria, whereas the unequal pupils is not always related to underlying condition. It may be caused by the physiologic anisocoria, a condition where the pupils is naturally differently sized because the use of eye drops, entry of certain medicines or chemicals into the eye. A relative afferent pupillary defect, otherwise called Marcus-Gun pupil. Some common causes of RAPD includes optic neuritis, ischemic optic disease or retinal disease, severe glaucoma causing trauma to the optic nerve, direct optic nerve damaged, trauma, radiation tumor, and retinal detachment, very severe macular degeneration, and retinal infections. Then tonic pupil, common in women in the third or fourth decades of life, but also can be present in men. Unilaterally dilated pupil with light or no reaction to light, but sluggish reaction to the near stimulus. Then Agal-Robertson pupil. Pupil fails to react to light, but constricts on convergence. This is inverse Robertson pupil. It is usually described as the ascripted to the central nervous system dysfunction. In this, pupils are reactive to light, but poorly reactive to near stimulus. Ameretic pupil, eye having a no light perception, will have no direct pupillary reflex, but contracts consequently when the fellow eye is stimulated by the light, provided the fellow eye is normal. And Hutchison pupil, it is a fixated dilated pupil, usually unilateral. It occurs due to the CNS lesion that compresses the optic nerve. Patient tends to be very sick. Horner syndrome. There is a clinical trial for Horner syndrome, ptosis, meiosis, and anhidrosis. Ptosis is the drooping of eyelid, and meiosis is the pupillary constriction. In anhidrosis, there is a decreased sweating. And as we see before, the structural anomalies of pupil will be anisocoria. There will be unequal pupil size. Then polychoria, the number of pupils. There will be no one pupil. There is a different size. Number of pupil size will be varied. And this is the first tuned pupil. Thank you.
Thank you so much, Gnanambighai. It's a very good presentation. Now I request Daksha ma'am to add your inputs, ma'am.
Hi, am I audible?
Yes, ma'am. Yes, it's
Yeah.
clear.
First of all, thanks to Dr. Agarwal's Institute of Optometry for having called me here for this very basic session, which I feel is very important. Even after so many years of clinical practice, I think there can be some times where even after so much of experience, we can still miss out on things. So it's really very important. So thank you, Agarwal. Thank you, Anshika. Thank you, Meenakshi. Thank you, Gomati, for whatever coordination we had to do. And now Gnanambighai, I just mistaked her word, her name. It was a very good presentation, very well presented, especially, the way the procedures are to be done, because these are very important and very basic things, which, in maybe in a hospital setup, maybe you do it because you have the template mentioned. So automatically you remember to do those things. But when it comes to, suppose if you don't have a template with you, you may miss out doing these things. So it is always good to have this within the template. You have mentioned things very nicely and very clearly. There are a few things which I want to add. Okay, first, I just want to, I don't have any presentation, but there are just few things which I just want to, 1 second. Yeah, are you able to see my screen?
Yes, ma'am. It is getting shared.
Yeah.
It's visible now, ma'am.
Okay. So if you see, I have just put okay, yeah. This is a picture. So now why I have put this picture? I think she's also shown this similar picture. But just for students to be more, understanding this. See, I'll tell you very frankly, when I was your age or when I was just newly practicing, all this. Maybe, we just used to do the broad hedge test and just like, document. But, down the line, I have realized that there are so many other things which you can pick up while you're doing the EOM testing and all of these tests, whatever she spoke about. And there are a lot of easy ways to remember how you can actually get so many diagnoses from whatever you do, especially EOM and cover test. There are a lot of things which we can actually diagnose. So this diagram, now all of you already know this diagram, which denotes, which side is the action of the particular muscle. Okay. So here I just want to point out, if you all remember the anatomy, this is the anatomy of the muscles. I really want to actually point out only the depressors and the elevators, because the lateral rectus and medial rectus, it's very easy to remember, which side the muscle moves, that side is the action, and you come to know whether it's overaction or underaction, and hence you diagnose a palsy, a lateral rectus palsy, or whatever. Okay. But this particular thing I would like to point out now, this is your superior rectus. Okay. And if you see, this is your midline. So superior rectus is actually making a 23-degree angle with the midline. And the superior oblique makes an almost 51 or 53 approximately. Different books have it mentioned differently. So this is the reason why we are actually checking the actions of these in these particular direction. Now, for example, now this is the patient's right eye. Okay. So if you see, we move H, when we do the H test, this is how we are moving it. We are moving it like this, then we are moving it like this. Why it is written SR here? Okay, SR is here, but here beyond 23 degrees, okay, or beyond 10 to 15 degrees itself, when you move the eye, you're actually seeing the actual elevator of the eye, which is the superior rectus. So when you move the eye like this, and then when it goes up like this, here is where is the pure action of superior rectus. When you do it here, it is not, it is just elevation. Okay, this is the pure action of superior rectus in abduction. Okay, so here is where we see so that's why it is important to move it out and up. Just moving up is only going to give you elevation and depression. Okay, so this part I wanted to just point out. So when you're doing this, you're actually seeing the action of the superior rectus of the right eye and your superior oblique, sorry, inferior oblique of the left eye. Okay, I forgot. I'm sorry, I should have put another picture of both the eyes. Okay, so just imagine a mirror image of this. So when the eye is up and out, when the right eye, the left eye is up and in. Okay, so you're seeing both the elevators in their respective secondary actions. Okay, I hope you're able to follow this. This is one important thing I wanted to point out. So when you are actually documenting, this is what you're doing. See, here we draw the diagram like this. Reason being, this is where you're seeing the action of superior rectus in abduction. This is where you're seeing the action of inferior oblique in adduction. Okay, so all of you know that a very important thing what I want to also tell you all, maybe I'll just write it down on the whiteboard, because since Gnanambighai did not mention, I don't know if all of you know this. We learned this when we were studying. One second. Yeah, so this is what I wanted to tell all of you. So it's a mnemonic which we were taught. Okay, it's called SINRAD. Does anyone know about this? Has anyone, I mean, I don't know how to know whether anyone knows about this. What is
Uh,
SINRAD?
Students, you can type the messages in chat box.
Yeah, and another, this is very easy, I think. Easy to remember. So, if you know this and, you can diagnose a lot of things. Uh, is there any answer, Meenakshi?
No, not yet, ma'am. You
Okay,
can post the
fine.
answer, students.
Okay, so SIN-RAD is SIN, superiors S, intorters. Superiors are intorters. So it means superior oblique and superior rectus both are intorters. And RAD means recti are adductors. All your vertical recti are adductors, which means your superior rectus and inferior rectus, they are adductors. So it automatically means that inferiors are extorters and your obliques are abductors. Okay, so this is a good way to remember. It's a good mnemonic to remember. This we were taught and it's still fresh in our mind. Another one, this I'm sure everyone knows, SO4LR6, that is your superior oblique is supplied by the fourth nerve and lateral rectus is supplied by the sixth nerve, which automatically means all the other muscles are supplied by the third nerve. Okay, so these two things, if you're able to remember while doing your broad edge test, it's going to be very easy for you to remember things. Okay, another thing which I wanted to point out is this. So it was mentioned edge test, right? Broad edge test. So we do it like this, going up, going down. Okay, again going like this, and like this. So this is how it is an edge. Okay, and what you're actually seeing in the in the extreme gazes. So these positions which have been shown are actually the 6 cardinal positions. Okay, so why are these important? Because at each of this point, we are actually seeing an important action of every muscle. You take, for example, here up and right. So in this up and right, you're actually seeing the action of the right superior rectus and left inferior oblique. That okay. So this is just an example. So like that, everything has been mentioned. That is why we call them as the 6 cardinal positions where we are looking for action of each muscle in each of the eye. Okay. Apart from this, it is very important that apart from this particular edge, it is important to even do a straight up for seeing your elevation and a straight down to do your depression, to know the depression. Okay, so those are primary actions of your superior rectus and inferior rectus. Okay, because the broad edge test is not showing those position, we have to do up and down as well. It is important and we are not supposed to miss that. So, what we are actually doing are the 6 cardinal positions, and the rest two are to be done separately than the broad edge test. Okay. So, I'm not going to go into the detail of, primary, secondary, and tertiary actions because all that you already know. Okay. She mentioned that, in the documentation, you basically draw this and see, there are many ways to actually document. What was mentioned here was one of the ways to document. In that, she mentioned about a scale, right? Plus one, it's like +1 or -1. So actually, it's called a 9-point scale, which goes from -1 to -4 to +4. Okay, so it's like a 9-point scale, and each number denotes a 25% underaction or overaction. Okay. Another thing, what I want to point out is we actually also see the amount of sclera shown. Okay. Now suppose you see the patient's eye. Now I am taking this particular gaze, for example. Okay, so there is no scleral show here. Okay, and over here as well. When there is going to be some kind of overaction, you may be able to see the scleral show here as well as here. So based on how much of muscle has been affected and how much of underaction and overaction is there, you're going to actually diagnose. So this is the midline. And if the patient is able to move halfway from here to here, then it is grade 2. That is only 50% the patient is able to move. If you see a very small scleral show, then it is 75%. If you see a lot of scleral show, then it is 25%. And sorry, I told the other way around. And if the eye doesn't move at all, then it is 100%, which can either be plus or minus, whatever that you should be able to tell. Okay. So this is another thing which you're supposed to note. So, grading may vary between person to person. It comes more with the experience. Okay. But it's important to.
So that is important. Okay, what I was talking. Yeah, nystagmus may indicate some kind of neurological condition. So it's important to document that as well. While the patient is doing, extreme gazes like right, left up, down, you do ask them about pain as well as one more thing.
Double vision. Okay, double vision also may indicate certain other things, any neurological conditions or any kind of palsies as well. So I think this is about very important. Don't forget to check on elevation and depression. Just 1 second. 1 second. Yeah. So the next, what she was talking about, are there going to be questions after each of this, or in the end only the questions are going to be there?
We'll keep it in the end, ma'am.
Okay, fine. So let's move to cover test. So in cover test, I want to just make us again, she has covered it quite well. Okay, so
What I was saying is this.
There are two things what we actually do. What I was saying is when you're doing a cover uncover test, it is very important that you don't miss out on doing a cover test before you start with the. I have seen a lot of students and optometrists, they do one eye and then they directly start the alternate cover uncover test. Okay. So what happens at that time? You have the tendency of missing out any tropia or especially alternating tropias. Okay. So we have to do a cover uncover test for quite some time and then we move on to alternate cover uncover test. Now, I had just shown a picture of why we need to, or if possible, you can use an occluder which is translucent. This will help you to see under the cover. So suppose if you are able to see under the cover with the translucent occluder and you see a movement, that indicates a phoria. The way to diagnose is the same thing only, just giving you an additional thing that you can also note the eye under the cover. But we don't use it too often because anyway, we have the alternate cover test to diagnose the phorias. Okay. So it's another important thing about cover uncover test is when you start, keep it in front of, suppose you're taking right eye, continue with the right eye for some time before moving on to the left eye. And before you move on to the left eye, have a time gap of like few seconds so the eye is able to regain the fusion which you have broken. Okay, these things are important because small deviations you can only get to know through these things. Okay, so you start with your right eye, do it, and again important to keep the occluder for some time, like maybe 2-3 seconds, and then remove it. Do it 4-5 times, then move on to the other eye. Okay. So you mentioned about visual acuity as well. This is not really followed. I have seen a lot of students, they directly give the 660 target. Okay. So the reason why we give this is in order to relax their accommodation for distance. I'm saying for distance. So it's very important to give the right target. Again, while you give the target, we are supposed to also tell them or ask them whether the letter, whichever letter, see, also, what you can do is suppose if you're giving an entire line, you can't tell the patient to keep reading the line because if the patient reads the line, he's going to move his eyes. So it will become difficult for you to actually get to know whether he has tropia or no. Rather, what you can do is ask him to fixate at one particular letter in that line. And what you can do is, suppose you had some letter like X or A in that line, you can tell them to fixate at the center of that X or top of that A. A particular sharp focus letter will actually make a lot of difference, and there will be a lot of concentration the patient will have. And for you also, it's going to be easy to detect. So these are small things which you should remember. Another important thing is you should see which eye has what vision and then give him the target. There are like when you're just graduated, and when you're just trying to know how to do a cover test, you might end up giving 6/9 to everyone, whereas the patient's vision is best corrected visual acuity is 6/18. So if you give 6/9 to the patient, when the eye which has 6/18 is seeing the target, it is not going to be clear. So it's very important to give the right visual acuity line target for the cover uncover and the alternate cover test. Always one line above the best corrected visual acuity. Okay. Then what else? Yes. Now moving on to the alternate cover test. So we know the alternate cover test is to detect phoria and tropia. It's important that you are going to, when you do the alternate cover. So now you have got to know whether the patient has tropia or no. You have done the cover uncover test. If there is no deviation in that, it is very clear that the patient has no tropia. Okay. So now you move on to the alternate cover test. Here you're going to cover the eye and then move to the left, the other eye, and you keep it for a few seconds and then move, so that the time for which the occluder is kept in front of each eye is also important. If you move it too fast, it's not going to be helpful in breaking the fusion. Okay. But again, remember not to keep it for too long as well. So keep moving it, like maybe for 2-3 seconds in front of one eye and then on the other eye, and keep doing it. So along with noting the deviation, it is important to even note the speed of the movement. Okay. So remember, you're actually seeing phoria and tropia here. So it is important to see the speed with which it is coming back and taking up fixation. Why? Because this is going to help you to decide what is the prognosis of the particular tropia or phoria, and it's going to help you to decide on what kind of treatment the patient needs. So the speed, we call it as recovery. Okay, and we can mention. I'll just show you how to document. So recovery is what we mention it as. We write it as like good recovery or poor recovery. Okay. So if it's taking a lot of time for the eye to regain fixation, it means the recovery is poor, or you can say poor fixation. Okay. So that's how you mention it. So that may indicate a poor prognosis of the strabismus. If the recovery is good, especially that is seen in cases of intermittent exotropia or alternating exotropia, which we can otherwise call it. In those cases, if the recovery is usually good, and hence we can conclude that your basic orthoptics exercise itself can help the patient. Okay, so I'll just show you 1 second. Yeah. So also we can find vertical squints as well. So while documenting vertical squints, we usually write it in terms of the eye which is in a hyper position. Okay, there is hypertropia, there is hypertropia. So if your left eye is hypertropic, we still write it as right hypertropia. We usually mention in terms of the eye which is at a higher position. Okay, so that's how it's a standard thing which is used. Let me 1 second. I'll go back to the presentation itself. I just want to show you how to document. My screen is visible.
Yes, it's visible.
Okay. So while writing cover test, you write it as, if it is there in your sheet itself, good. Otherwise, you can write it as CT or cover test, and then you're going to write it as, like, see, this is very important because I have seen students not writing it really right. Okay, so we know this how it is done for both distance and near as well for 33 centimeters. So we'll write it as cover test distance. If it is ortho, we write it as ortho. If it is see, there are a lot of things we write it as esophoria or tropia or exophoria or exotropia. Okay. And then in bracket, you're going to write it as 9 prism diopters. Okay. Base out. Okay. That's your PBCT, what you do. Okay. So this is just a rough documentation, what I've just mentioned. You can write PBCT separately as well, or you can write it like that. Okay. So this is for a phoria or a tropia. Now, suppose you have an exotropia, or you have an alternating squint, then you can write it as AXT. XT is your exotropia. Okay, and then again, same thing, you're going to mention it as how much ever prisms you find. And you can write it as maybe good, sorry, in bracket, you can also write it as good recovery. Okay, or poor recovery, or whatever your finding is. Okay, and then you can write how much is the prism diopter of AXT, or, and then same thing you're going to write in for near. Okay, I have seen a lot of students writing it like this. This is wrong. There is nothing called as mild exophoria or moderate exophoria. Whatever it is, you're supposed to quantify it. Okay, your and quantification not necessarily has to be written like this. You can just write it as exophoria, and in your PBCT you can write whatever it is. Important thing what I forgot here is with RX, or obviously if it is with RX, without RX not needed. Okay, so this is the right way to write cover test distance and near. This is how it is actually, standard way to get to know how it is actually, what is the actual squint the patient has. If you write mild exophoria, or some people write it as right eye exotropia, I mean, that's not the right way to do it. Now, this is alternating I have written. If you have it in one eye, then you're going to write it as left esotropia. Okay, this is how you write it as. Okay, so I hope this is very clear. Then there is also a way to know whether you have done your cover test right or wrong. Okay, how you can do that is by putting a 4 prism in front of any eye. Okay, if you think that you have done and you see that it is orthophoria, but maybe you just want to know whether you're right or no, you can just, there's an additional thing what I'm telling you. It's not necessary you should do it, but then you can try to do it so you can learn more from all this. Place a 4 prism base in and then base out. So when you do a base in front of any eye, you can keep, what will happen? The eye which is ortho will become esophoric. So when you place that and then you do a cover test, you should be able to see an exophoria. Okay. And the other way around also is true. So if equal amount of squint is seen on placing 4 prism base in and base out, that means your test is right. What you have done is correct. Orthophoria, what you have documented is correct. But if you're able to see, more esophoria and less exophoria after placing the prism, that means maybe you have missed out on some small squint. So maybe you need to redo the test. Okay. Uh, Yeah, so one small question. If you see no movement, I think I already answered this question, but let me just check if you really heard me. If you see no movement on cover uncover test and you see some movement on alternate cover test, what does it indicate? I'll just wait for a minute to see if there are any answers in the chat, in your YouTube chat. Again, I'll repeat the question. If you see no movement in the cover uncover test and you see some movement in the alternate cover test, what does it indicate?
Phoria.
Why did you answer, madam? You are the presenter. Yes, the answer is right. It indicates that the patient had phoria. It's a very simple thing. I just wanted to see if you guys are able to understand. If you understand this, then it's, you're good to go. That's what I mean to say. Okay. I think I'll just talk for a minute on PBCT. PBCT is your prism-based cover test to find the amount of prisms. Find the amount of squints. So you just have to place the prism in front of the eye which is deviated. And in cases of phoria, you can place it in front of any eye. And the way to place it is apex towards the deviation. Okay, so suppose it is a left exotropia, you're going to place the prism in front of the left eye, base in front of the left eye. You will go on increasing the prism and you place the prism in front of the eye which is deviated and do an alternate cover test. You go on increasing the prism power until you see no movement or a reversal of the movement. So the place where you see no movement indicates the amount of tropia in the patient's tropia or phoria in the patient's eye. So that is what you're going to document. So PBCT is a very important test, but PBCT does not differentiate whether it is a phoria or a tropia. That point also has to be taken into consideration. Okay, so this is about your cover test. I just forgot to tell you about documentation of uh, extraocular muscles. She mentioned about the diagram. In few places, diagram is not drawn. We just write it as full, free, and painless. Okay, which means full means the movements are full, they are free without any restriction, and they are painless. Okay, we write it as full, free, painless, or we also write it as safe. Okay, safe is, I think, globally followed. It is a smooth, accurate, full, extensive ocular motility. Okay, I have not seen much of it being used here. We used to use full, free, painless, and if there was any under or over action, we used to draw the diagram which Gnanambighai has mentioned. Okay, so it's not always necessary you have to draw that diagram. You can just write full, free, painless as well. Okay, so because again, you don't know how much space is there. In Shankar Netralia, the sheet itself had the drawing done, so it was easy to document that. Full, free, painless is good enough. And regarding pupils, she has already mentioned almost everything. I just wanted to show uh, one thing about direct and consensual. If there is some thing you find in the direct and consensual, this is how you can Perla, as she mentioned, pupils equal round reactive to light and accommodation. So this is the grading for the response of your direct and consensual. Okay, so she had mentioned about mild and those things, right? This is a more standard way of mentioning it. If there is no response, then it is grade 0. Barely perceptible response is 1. Minimal response is 2. Moderate is 3. Brisk pupil round. See, there is also another way to document RRTL, round reacting to light. Okay, this is also another way which we used to mention. So if you find some other response, this is the grading of pupils. Okay, and she has mentioned about swinging flashlight as well. If we have time, I just wanted to know if I can show you a video of how these two gradings are done. Just let me know, Minakshi, if we have time for that.
Yeah, ma'am. We can see the video.
Okay, fine. I'll just show you the video. My screen is visible, right?
No, ma'am. It's not visible.
Why does this happen? I didn't share the screen, sorry. Now,
Yes, ma'am. It is getting shared.
are you able to see a YouTube video?
Yes, ma'am.
I don't know why the audio is not playing. Is there anything like the YouTube audios don't play?
No, no, ma'am.
None
It
of
is
you.
audible.
Yeah, so okay, fine. You can. Oh, why should this happen? Okay, let's see if you're able to understand because what she's talking is very good. Okay, grade one. We're going to talk about grade one now. So just see this grade one. Okay. I'm so sorry this is there because it'll be better if the audio was there. Okay, this makes no sense. Leave it. Even the same thing, I don't know why this is happening. Why this usually happens because you're already connected on YouTube or something.
Maybe, ma'am.
I don't know why this is happening. Okay, then I think I also wanted to show there's another way to grade RAPD. It's using the neutral density filter. Okay, one is what she has already mentioned. And see, again, in doing pupillary evaluation, the way the swinging flashlight is done is also the number of times, and then your the way you swing it and you keep it, you're supposed to keep it like for a couple of seconds and then move it to the other eye so the light reaches the back part of the eye. You can't just keep swinging like that, so the amount of time is also important. And you may end up missing out if if it's complete dark room. Okay, so there should be a little bit of light for you to little bit. Like you have your distance chart on, right? So that amount of light is okay. You cannot have a complete dark room. One grading is what she showed. The other grading, which is not generally followed, but it is your neutral density filters. So you have filters in log units. These density filters are in log units. So you just place filter log unit wise in front of the normal eye, okay, not the eye which has RAPD, and then you try to see whether you're able to neutralize the RAPD, like the amount of RAPD which is happening or the reaction which is happening in between both the pupils. You try to neutralize them, you try to make them same, and the point at which they become same is the amount of RAPD which is present. I had the video, maybe I'll share the link, you can send it across to the students. Yeah.
Yeah, ma'am. Thank you so much, ma'am. We just had a couple of questions, but that got addressed meanwhile while we discuss about the procedures, ma'am. So they just
Okay.
asked how to differentiate between tropia and phoria in cover test, and how to we grade the magnitude of tropias. So that we discussed about the recovery point and how to classify between phorias and tropia in cover test. Then, while
Okay.
measuring pupillary evaluation, what is the need for measuring size and shape of the pupil?
Come again, while measuring size and shape.
of the pupil. We do test for reactions, but then we also measure
Not
for
able
size
to
and shape
hear.
of the
Hello?
pupil. Am I audible? Ma'am, can you hear me now, ma'am?
Yeah. Tell me.
While doing pupillary examination, we also measure about the size and shape of the pupil. So, what is
Exactly when
the
you're telling me
use
the
of?
question, your voice is not audible. Sorry, if you can type it, because you know
Yeah, ma'am.
exactly when you're telling the question, it's getting there's some. Why is the size and okay? Why is the size and shape of the pupil important? Okay, shape of the pupil is important because there are a lot of ocular diseases where you may see different shaped pupils. Okay, again, that is another big session on ocular diseases. Size is important because one is um, knowing the size in normal illumination and dark illumination is very important because of how much of light is going to get into your eye. For example, now it's also very important to measure this when you're using contact lenses. Why? Because the optic zone is the area where the power is. If your pupil is going to dilate more than the optic zone diameter of the contact lens, then the patient is not going to find it easy to see through it. He's going to have a lot of issues with diffraction and those issues which will happen inside while the light rays get inside the eye. Okay, and then if your pupil does not dilate, if you have a mydriatic pupil and there are the dilatation, enough amount of dilatation does not happen in the semi-dark room, then the patient might have a decrease in visual acuity as well. Okay, so this is related to the size of the pupil. And you also have to compare between both the eyes. So all of you know that difference in pupillary sizes between both eyes is called as anisocoria. That can be indicative of some kind of pupillary abnormality, which I think Gnanambighai already spoke about. Anisocoria we call it as. So anisocoria presentation can be indication of some diseases as well.
Thank you so much, ma'am. So, we are done with Q&A session also. Anshi, ma'am, do you have any questions,
Okay.
ma'am?
No, I think we had a very, very extensive session. Thank you, Gnanambighai, and thank you, Daksha, for bringing out the importance, the nuances of how each and every step is important. It was very nice by Gnanambighai to show how the procedures are done, and Daksha brought about the importance of why simple things like moving it completely to the right and moving it up in broad edge test. What do we exactly test? Or when we are doing pupils, what is happening when we are checking the size and shape of the pupil? Or when we are doing cover test, just don't do one eye and leave it because you might be missing out on the other eye. So these are very, very small points, but as the topic suggests, back to basics is very, very important. And I'm very happy. Thank you, Daksha. Thank you, Gnanambighai, for bringing about all the important aspects. And it's a very, very fruitful session. I think students are going to really love it to go back and they can revise their CVS, these three procedures anytime, anywhere, always available on YouTube. So thank you so much. Over to you, Gomati.
So thank you so much, Daksha ma'am, for joining us today's moderator. Thank you so much, ma'am. And Nanchi ma'am, thank you so much. Meenakshi, Nanchi ma'am, thank you so much for your continuous support. Gnanambighai, this wonderful presentation. And on behalf of Dr. Agarwal's Institute of Optometry, all the staff members here, we would like to wish all our students all the very best for your exams, as this is the exam season at DIO. If you like this video, give a thumbs up and share with your friends. We'll meet you in the next episode. Thank you, Daksha ma'am.
All the best, students, and thank you for inviting me. Thank you.
Okay, ma'am. Thank you so much, ma'am.